Can you see my screen?
Yes, we do.
Great. Thank you so much. So good morning, everybody. So today I'm going to share a little bit on interpretable machine learning based scoring system for clinical decision making. As you know, that AI is very broad. It includes all kinds of methodologies. And among the AI, there's one branch called interpretable AI or interpretable machine learning, so which is potentially has a good fit for medical and healthcare applications. So that is the scope and focus of today's talk. So the first slide I put here is, one illustration. Suppose that one patient collapse outside hospital, and then a healthcare professional is trying to provide a treatment to the patient. Assume that you have a black box AI that predict the chance of survival for this patient is 5%. And then naturally, you probably have a few questions, right? How does this AI make the prediction? And is the prediction trustworthy? So what if the prediction is wrong? Instead of 5%, the actual survival rate is 80%. So those are the questions that we often ask. That's whenever we're using a black box models, and that is the motivation that people start to look into interpretable machine learning solutions. So here I use introduce some of the fundamental principles as I borrow the concepts from Professor Cynthia Rudin's paper, so which is very important. I highly encourage all of you to read it. To read
Mm,
it. And then, the first principle is really about the interpretable machine learning models obey a domain-specific set of constraints. So this is important because you probably can apply AI or at the black box or interpretable solutions for dealing with problems, but it is very important in healthcare applications. So we have to consider domain-specific set of constraints. So this is the foundation for building AI solutions for healthcare and medicine, right? So these constraints can differ dramatically depending on the domain. So even within the healthcare and medical domain, there are different, medical specialties, right? The constraints within acute and emergency care will probably be different from the constraints in cancer or cardiology research. And the second principle is that many people feel that if I can explain the black box models, I probably can gain some trust from the users. This may or may not be always correct, right? So the explanation of the interpretability to the models can simply allow the users to decide whether to trust or not.
mm,
It's not really, by explaining the model, you can provide, 100% trust on the model itself. And the third principle is often, a misunderstanding, right? So most researchers, or many researchers, especially from the clinical field, feel that if I can build a very complex black box models, I can always achieve a high performance. So on the other hand, if a model is interpretable and simple, perhaps the performance is not as good as a complex black box models, which may not be true. So because if you can really see through the key components of your model, and those of the information that are fundamentally important in making driving the decision making.
oh, oh, back at home.
Is there
Oh,
sorry,
let
is there
me
echo
mute.
or
There is someone's. Okay, sorry.
okay?
I muted other people. Okay, it should be
Great.
okay.
Yeah,
Yeah.
thank you so much.
Mm-hmm.
So it is important that to not to assume that one needs to make a sacrifice in accuracy in order to gain the explainability or interpretability. So because very likely if you have a much better understanding on your model, the predictors, the outcomes, and how does the predictors contribute to the outcome prediction, even though your model can be simple, it may still be powerful and also as accurate as the black box models. And the principle four is really when we talk about the reporting of the model, that in addition to reporting the performance metrics, is maybe sometimes it's equally important to providing certain level of interpretability metrics. For example, in the structured data analysis, your model can be, as simple as a scoring system, or in the medical image analysis, you can provide heat maps to highlight the regions that may be driving to the prediction models and decision making. And perhaps you can use a SHAP or LIME or some of the post hoc explanation methods to explain the model. And lastly, and especially for high stakes decision making, like in healthcare, interpretable models should be used if possible. So, of course, you can feel free to explore the use of black box models, but to provide a certain level of explanation, and ideally, if you can create an interpretable or even fully transparent model, that would be ideal. So as I earlier mentioned about actually within the field of interpretable machine learning, so perhaps we can roughly separate the methods into two parts. So the one part of the methods is a fully transparent interpretable model, such as the scoring system, decision trees. So the other part of the models often considered as black box models, but I'm using some algorithms like a SHAP or LAM to explain the models even after building the model. So in this talk, I try to focus on the prior parts, which is the interpretable and transparent model, which is using scoring system as one example. So there's a pressing need in healthcare regarding the use of interpretable machine learning models. Is because the black box models are not often favored in clinical practice, especially when clinicians want to understand what is the driving factors within the model to allow them to make a decision making. And especially for high stakes decision making. So as I mentioned earlier, that if a patient collapses with a heart attack or maybe cardiac arrest, so it is very important to understand how AI is used to drive the decision making. And so that the doctors can understand, doctors can explain the models to the patients, or perhaps the patients or their relativity understands so what is happening within it. So scoring systems actually is, are often considered as inherently interpretable models. So as also, summarized in Professor Rudin's paper, that's actually there were different types of models that consider as interpretable machine learning models. So in this talk, I only focus on scoring system, but if you have interest, you can, explore other types of interpretable machine learning methods such as decision trees and, generalized additive model, case-based reasoning, among others. So this is, slides give you two examples on what are the sparse scoring model look like in healthcare. If you look at the figure on the right-hand side, so this is an example of a national early warning score. You look at the left side of the table is a list the variables, right? It can be SpO2, pulse, and temperature. So those are the variables, and the columns on the right-hand side actually indicate the based on the cutoffs of the values of each variable, you can assign a corresponding scores to those variables. And ultimately, you can just simply add up all these scores for all the variables, and you can have a final score. So by using scoring system, actually, you can easily infer variable contributions to prediction, right? Again, I mean, if you look at the National Early Warning Score for temperature, right? If a temperature is the bottom of the table,
Hmm.
if a temperature is more than 39.1, degrees Celsius,
Mm.
a score of 2 will be assigned, which is considered maybe, some risk. But if it's a temperature is between, in the middle is 36 to 38, essentially score number is 0, meaning that, the range of the temperature is normal. But on the other hand, if you look at the far left, if the temperature is less than 35 degree, then the score is assigned at the 3, means that if your temperature is too low, actually the chance of having a bad outcomes is also high. It's equally even have a more weightage compared to a higher temperature. So this is the true value of having a scoring system because it's so easy to understand. It's so easy to explain to anybody. So next, I will spend a few minutes to briefly introduce AutoScore, which is an interpretable machine learning-based framework for risk scoring, development. So as we know that, traditionally many risk scores were based on or derived based on the expert and consensus meeting through the literature reviews and examples, SOFA score, news score. So those scores may be a little bit subjective, depends on the experience and knowledge of the expert, committee that's determining and deriving the scores. Or the other alternative approach is to, build up a cohort, study and through analyzing the data within the cohort so that you can derive some variables that's considered significant to be part of the scoring system. Examples, Apache score, CART score, HAS score. So those are the scores, still traditional, but the way that they were created is maybe time consuming. It's not so easy to update and to adapt to a different, environments. So there's an unmet needs in the current literature. So we really need a comprehensive interpretable machine learning framework that can be scalable to automatically or maybe semi-automatically develop a scoring system, especially in the era of big data, where that we have access to very large electronic health records. And the AutoScore framework that is considered as the general methods for developing clinical scores using structured data. So the scope of the framework is for dealing with the structured data, not for imaging analysis, not really for omics data analysis. But the output of the framework is the sparse and interpretable scores. Essentially, the framework includes 6 modules, and the modules can be updated independently. So is when if you look at the chart on the right-hand side, when you have an input data, we split the data into essentially 3 major paths: for training, for testing, and for internal validation, parameter tuning. And the first module that is essentially a variable importance analysis. We're try to understand, so among all the variables, so which are the important ones? And follow that, so we will build up transform the variable list. So the reason that we do the variable transformation is because we have to determine the cutoff so that we will convert this continuous variable into a categorical one so that we can assign the different scores based on the cutoffs. And the module 3 essentially is for deriving the initial score, and then through module 4 that we have model and parameter selection process through a parsimony plot. I will elaborate slightly in the later slides. And there will be a process of fine-tuning that conducted within module 5. And module 6 essentially is for producing the final model and reporting the results. So let's just take a look at the first module, which is variable ranking. I think that you should be very familiar with variable ranking. You can say it is, variable selection, variable ranking, feature selection, feature ranking, variable importance analysis. There are, all kinds of methodologies for dealing with the ranking of the variables, and the criteria for determining the ranking can be diverse. right? You probably can simply use a p-value or odds ratio to determine the ranking, or you probably can run a random forest or maybe XGBoost, or other machine learning methods to determine the ranks of the variables. In this study, by default, we're using random forest. We know it is not a perfect solution, but the random forest is considered, one of the top one and often easy to implement, and the results are often quite reliable. But of course, we have the options to change, from the random forest to other types of variable importance analysis methods. And the module 2 and 3 essentially is to do the transformation and to fit the model, right? So we also, I mean, again, use a very simple and straightforward methodologies for do the variable transformation. We set the quantiles, right? So based on, create the variables, continuous variables into five groups. And so that's we can determine the category, and so that after we can converting all the variables into a categorical one, so that we can fit the largest regression model for scoring weightage calculation, and ultimately we can create a risk score. And the module 4 essentially is the core uh, of the framework, whereas we do model evaluation and selection. And the novelty here is that we try to create a parsimony plot on the internal validation set. And
Mm,
the idea is quite straightforward. If you look at the chart here, that's the x-axis is the list of variables, and in the order of the variable ranking we obtained in module 1. And the way that we do that is if we fit the first variable, the top ranked variables into to build a model, so we can get AUC value. So for example, if you look at the y-axis is AUC, and there each bar in this figure represent the AUC values. And then after that, we create the second model using the top two ranked variables. And we do the same for the rest of the variables. And it's very interesting, according to many, many applications and testing, we figure out that if we use all of the variables, and this may not be able to guarantee the best internal validation performance. But if you look at, as illustrated in the figure here, that's when you add the variables after six, you add the top seventh ranked variable, top eighth, essentially, creating the new model with small variables is not guarantee a better AUC values. So that's actually leads to a very important decision making that also allows a human to intervene this process. We have to determine, so how many variables we want to use to create a model. And in this example, we decide to use the top six, right? The reason is that, by adding in new variables, the performance will not be further improved. And also in clinical application, it is very important to reduce the number of information variables to be included in the model, because the more information you have, so ideally, the assumption is the more information will be leading to a better performance, but in reality, it's not. But adding in new variables and new information requires additional efforts in data collection, right? So suppose that if I have a model with six variables, and we have another model of 20 variables, even though the performance can be quite similar, but it's much, much easier to implement or create or use the model with only six variables, because clinicians can easily, get the six variables value and make a prediction. On the other side, if you have 20 variables, means even though, sometimes maybe you have to wait for 2 hours to get the lab test results. And in order to collect all the 20 variables, time has been at, quite late stage when you will be able to make a decision making. So we have to create, a parsimony that especially the performance versus the number of variables. And in traditional AI or machine learning research, maybe this is not that important, right? So what is the difference between six variables versus 20? So you give me the data, I can build the model. But in a clinical practice, as I mentioned earlier, that the reasons and justifications of using a minimum number of variables and information for making a decision making is very important and essential. And there are some, additional unique features of the framework. The one is that we allow the fine tuning of the scores. For example, here, if you look at the table on the left hand side, is the variable SpO2 that's according to the previous framework that we can determine four different intervals, and each interval leads to a risk point, right? It's quite okay, right? It's very simple to understand, but to clinician, it's not easy to remember,
Mm.
right? It's, for example, SpO2 of 79 is not 92, 97 are not commonly recognized, cutoffs. And then if we allow some manual adjustment to the cutoffs, for example, we can change the cutoff to 85, 85 to 90, 90 to 95, which is, can be, perfectly aligns with the current practical practice in medicine, or maybe the numbers can be much easier to remember. So we just need to rerun AutoScore framework so that we can get new, based on the new intervals, we will get a new set of risk points. So if you look at the left and right table, even though the risk scores may vary a little bit, but the intervals are much easier for clinicians and humans to remember, and it's much easier to interpret. So by doing this, actually, we're making the risk scoring models more orderly, professional, and acceptable to the clinical community, and that allows that users to determine the cutoffs based on their domain knowledge, right? So even though it's not really illustrated within the slides. So for example, the computer suggested the four different intervals, but if some clinicians feel that I probably just need the three intervals, then they can easily, change the cutoffs so that they can have a three intervals. And that is, highly customizable and flexible in adjusting the
Mhm.
cutoffs and combining the categories. And the last module essentially is, the model evaluation reporting is the usual, metrics like AUC values, PRC, the calibration. So those are the, commonly used, the metrics for reporting the performance. The package is online in the public, and it's a fully, all the source codes are accessible, and then you're free to adapt this or maybe make any changements to suit for your own preference or maybe your own needs. And we also publish another tutorial paper, so which is quite interesting because the example I mentioned earlier is a simple binary prediction scenario, right? So I want to predict, one from zero, and we also extend the methodologies of AutoScore to dealing with ordinal outcomes, to deal with survival outcomes. And here in this tutorial paper that we provide a step-by-step kind of protocols on teaching users and researchers on how to use AutoScore framework to deal with different types of outcomes. So next, I briefly give you a clinical example that's how we can use
Mm.
AutoScore. So here that we use AutoScore framework to create an interpretable triage tool for estimating mortality risk after emergency admissions. And the data that we collected is from Singapore General Hospital, so one of the largest hospital in Southeast Asia. But this is, only a portion of the data sets. We start with roughly 340,000 episodes of emergency admissions. Means that only patients who were admitted into the hospital were included. After some exclusion, so ultimately we have 28 280,000 for creating the training and validation cohort, and we reserve another 20%, which is 42,000 for as a hold after testing cohort. So the training data will never touch the testing data. So these are the candidate variables is roughly 60, 70 variables, including demographics, administrative data, medical history of the patients, clinical data like vital signs, some of the lab test results, medical comorbidities, right? Whether the patients have a history of a stroke, dementia, maybe among other disease. And the outcome that we are looking at is the 2-day, 7-day, and 30-day mortality that's after emergency admission. This is the final product that we have. We call this a score for emergency risk prediction. So even though the table is a little bit busy, but if you look at the three columns on the right-hand side, essentially they represent three risk scores, right? One is the 2-day risk prediction, 7-day and 30-day. And whenever that you use, you can just one column to convert that into a scoring table. Even though, remember that I use initially 60 to 70 variables as a candidate for feeding the model and trying to figure out, which variables are more important for building a risk score. And if you look at the final risk score, so I just need simply, maybe 6 or 7 variables to make a quite powerful prediction models. And those variables are easily accessible, like age, heart rate, respiration rates, blood pressure, SpO2, and cancer history. So
Mm,
when I presented these results to a group of emergency physicians, they were very surprised that, they asked, how come that you can use such a simple scoring table to create a model, and how can I trust it? So then I showed them the performance, right? So here is the top 3 rows, the performance of the 3 risk scores, and the bottoms are the comparators, right? So those are the clinically widely acceptable risk scores. If you look at the performance, essentially, the ICRP score is among the best, even though it's only requires 6 or 7 variables. It's quite powerful. And that means that I don't really have to use, all the 70, 60 variables. I just need to use simply the 6 variables. And if you look at, remember, those variables are very easy to obtain. I just need to ask a few questions, take a blood pressure check, and then I can make a decision. It's all these, the decision making can be done within the 3 or 5 minutes, which is very attractive to the clinical team.
mm, mm,
And here is additional, illustration on the RC analysis. And suppose that I here give you one example. If a patient A present to the emergency department at the age of 74, past 76, respiration, blood pressure, has the cancer history, right? So I simply feed this information into the scoring table that's built for 30-day mortality risk prediction. And for each variable that I can have assigned a risk score. And then ultimately for these patients, so he or she has a risk of 41 out of 100. I forgot to mention that, by default, we normalize all the scores from 0 to 100, but depends on the needs. You can always change the, from 0 to 50 or from 0 to 200. It's highly scalable and customizable. And based on the score, but more importantly, even though the risk is 41 out of 100, we don't really know whether it's a high risk or low risk. The reason is that we have to determine the cutoff. If the cutoff is 20, then looks like 41 score is considered high risk. But if the cutoff risk is a 50, and then at the risk score of 41 is considered as a low risk. But by using a score, and also you can analyzing a cohort of your data, you can essentially assign any patients into 3 groups or even more or less than that, right? It can be a high risk, intermediate risk, or low risk. if a patient is considered as a high risk, I probably, send that patients to ICU or high dependence ward for immediate attention. And for the other patients, I, keep them within the general wards. Or maybe some of the very low risk patients we can consider has a having a early discharge if possible, right? To save the space from the hospital. And the auto score essentially has been, used by different application, even though I mentioned about the emergency medicine application, and also there are, like a neurology, intensive care, this ONG, ophthalmology, pediatric renal medicine. So those are the studies have been published, not, only from my team, but also from my collaborators and maybe someone I don't really know that's from the US or from Europe, from Australia. So they have been using AutoScore framework to create risk scores for their own clinical applications. So now I just now, briefly talk about broadly what is interpretable machine learning, why it is important, and narrow down a little bit on my sharing to AutoScore framework, which is a specific methodologies and framework for dealing and creating, interpretable risk scores. Now I want to step back a little bit to look at, a real world challenge that's when we use AI or machine learning for clinical care. So
Mm-hmm.
this is, the slides shows a very nice, bed, right? We have a very organized the medical devices along the bedside. It's very clean. Imagine this is the setting that we built our AI model. The reason is that we collect a lot of messy data and we have to do data cleaning, and make it very clean so that, everything is organized, everything is in order. But imagine that when we implement the AI models in a real world setting, a real world scenario is very messy, right? For example, in the emergency room, you probably see hundreds of patients a day, and there were always patients, filling entire floor of the emergency room. And some are really bad in condition, and some can be walking around. And this is, quite, difference between the ideal setting and the real world setting when we talk about the AI model implementations. And that leads to a very important question, which is we really need an ethical AI framework in general to regulate or to guide the development and implementation of our AI and machine learning solutions. So this is our recent paper on we summarize, 9 or 10, major ethical principles within the use of AI for healthcare. Even though context here is the use of a generative AI, but we ultimately found out actually the principle that we summarize can be applied to a generic, AI applications for healthcare and medicine. So surprisingly, so within the ethics field, actually there are many, many areas that's very technical. Or maybe on the other hand, or if I change another word, that's many of the ethical considerations can be tackled by technical solutions. If you look at the figure on the left-hand side, the bottom, so I summarize like equity, transparency, privacy, security, or safety. So those are the ethical principles that have been widely investigated in from the computer science or from the engineering community, right? So there are lots of research on how to create interpretable or explainable AI to provide a transparency to the models. There are many research on fairness and bias research to dealing with the model to enable the model providing equity, equal kind of contribution to the clinical applications. For privacy preservation, there are solutions. But of course, I mean, there are some other components from the ethical field that is, a little bit less technical, but equally important when we talk about the AI implementations for healthcare. For example, the accountability that leads to a very fundamental question. right? The legal concerns, right? Liability issues. If I'm a clinician, I use AI to make a wrong prediction. So should I be liable, responsible for the wrong prediction, or will the AI developer be
Mm,
co-responsible for this wrong prediction? So there are a lot of debates and discussions. Autonomy refers to as the user of the AI, not only clinician but also patients. That the patient needs to know that the clinician is using AI, or whether clinicians or patients have the right to refuse using AI during the treatment and recommendation. And trust is another issue, and also in general. So our AI solutions should be doing and providing benefits to the patients rather than creating harms. And also there are also some other aspects like integrity for medical education and quality of clinical research. So essentially, I mean, we should really think a little bit broader, in addition to uh, the use of AI, right? So the transparency, interpretable machine learning, and AI is one part of a bigger ethical AI framework. And this is, using the same example, patient collapse, AI provide a 5%, survival chance using a black box model. Suppose that now I replace this black box AI with a simple scoring system that's only use a few variables. For example, the age, the time to, ambulance arrival time, the first rhythm, and whether the patient collapse, which is witnessed or not, and then whether drugs has been used or not. So if I can create a very simple scoring system that can easily to be understood, will that increase the trust? Will that increase the confidence that allow clinicians in making a clinical decision? I'm not pretty sure, but a certain level of transparency and explainability will always be very helpful. And the other one is the bias and fairness. So from the computer science fields and AI fields, there has been numerous discussions and methodologies for dealing with bias detection, bias mitigation, among others. But if you look at the figure on the right-hand side, it's a very interesting circle that the data will always contain bias. And if we do not make any adjustment to the data, and the bias within the data will be aggregated and transferred to the algorithm when we create an AI model. And again, I mean, if you do not apply any bias mitigation methods to the algorithm model building, and the algorithm bias, it will be, transferred and aggregated to a human implementation part. Suppose that clinicians are using the model containing bias in a real-world clinical practice, and together there are additional historical bias, behavior bias that's inherently coming from human beings, and the new biases will be again appear again in the data, in the new data. And since AI is a data-driven solution, we have to always update the model. And if the bias is through the different process aggregated through the cycle, and you can imagine that the model uh, will have a lot of problems when you really implement them into the real world setting. And the privacy and security reason, I don't have to mention too much, but different legal system, different country have their own policies on data sharing and the privacy protection. So it is very important. It's a very important consideration because ideally I can connect all the data into a central places so that I can analyze data happily. But in reality, very often that you cannot access other people's data, right? For example, if I want to access data from a case from IBS, there will be issues, right? At least we should sign a contract, and the contract has to allow us to make a data sharing. If not, are there any solutions? Yes, right. So there were federated learning, there were different, AI machine learning methodologies have been developed for dealing with collaboration without the data sharing. But although, I mean, the methodology and technology may not be mature enough, but again, I mean, there are solutions for allow us to think about, even though there is no data sharing, that how can we keep the privacy of the data, how to keep the confidential information of patients within my institute while doing a meaningful international cross-nation, cross-institute collaborations.
Mhm.
So the other part is about the safety issues. So it is ultimately very important, right? It's highly regulated by different regulatory agencies, right? FDA, Korean kind of equivalent FDA, the Singapore government. There were regulations, there were rules on how to keep the safety of the AI solutions for clinical practice, right? The way that we use the regulation is we have to ensure that we have a rigorous evaluation on the clinical performance, right? The performance, AUC value, sensitivity, specificity, through a validation study, can be observational or randomized trials, or maybe through the analysis of real world data. And then we have to also think about that, after using the model, whether it's a black box or maybe interpretable model, whether the implementation of the AI solution has created impact on patient outcomes, and what will be the change to the healthcare workflows, and are there savings in terms of the resource utilization. So those are the considerations beyond just building the model, especially those of the considerations are very important in healthcare application. Again, it's a field moving very fast, and there were opinions that coming from various group, and traditionally, I think I believe most of you are aware that in applications in papers, so most authors will mention about, oh, I built a model and perhaps I did the internal validation on my data set. So in my future work, I plan to externally validate my model in ABC sets or maybe even beyond my country. But if you follow up those studies, very unlikely you find out the external validation,
Mhm.
right? For various reasons, maybe it's difficult to get the data. There's no funding support for do external validation. But there's a study published last year is very interesting because it brought up another opinion saying that you
Mhm.
know external validation of AI models should be replaced with a recurring local validation. And so the claims that by the authors that rather than doing external validation, then perhaps you want to do a longitudinal local validation. So which makes sense, right? If you use your own model, like in Korea, that you want to validate your model continuously, every 1 year, 2 years, or maybe 5 years to ensure the model will continue to have a very good performance. But it really depends, right? So for some cases, you perhaps still have to consider external validation to evaluate the performance and generalization of your model in a different setting. So there's no right wrong answer on that, but it's just a different opinions on how to rigorously evaluate your model. And lastly, I think we go back to the very fundamental and the root of AI, which is the data, right? So the data is the foundation of everything. But there were many, many problems within the data that we should always think about, even before we create a model, whether it's a black box or maybe interpretable model. So data quality is a huge barriers nowadays because even though we have a very large amount of data, but often the data are messy, and there may be coding errors, maybe a lot of wrong information. For example, in our study, we sometimes found a patient is aged 200-year-old, maybe a blood pressure with 1,000 200, which is impossible. You have to make sure that your data is in high quality, and when you talk about the medical image analysis, you have to ensure that the image is not blurry, is very clear. And another perspective for data quality is really the data changing dynamically, right? Build a model using a historical data, and you can probably apply the model today, but 5 years later, 5 years later, will the model be still valid is another question, right? The Asia is seeing aging population, right? So 5 years later, there were more elderly patients in the hospital. So you have to think about whether your model is still valid or not. And then, there were lots of missing values in the data set, especially when you're dealing with lab test results, or maybe even some of the, rare events, rare disease analysis. And you probably do not have access to a large amount of data. Or if yes, then there are still a lot of missing values. So that creates, another layer of challenge. But lastly, I think we're I believe that most of us are scientists, right? We're dealing with the data, we're dealing with the methodologies. So we do should acknowledge the importance of domain knowledge. It is equally important to understand the data and also to learn about a little bit on the clinical hypothesis of the study and how the data collected, how the data and variables are defined, and what is the reason and what is the idea of creating a model and how the model can be implemented in the real world setting. So those are the missing part and sometimes the gaps within the current health data science, healthcare AI applications. So we should always work as a team in producing a meaningful and perhaps feasible and valid AI solutions. So with this, I end my talk and happy to take any questions. Thanks
Mm-hmm.
again for the invitation.
Great, none. Wow. Okay, so thanks so much. So let me stop